and then we'll do some introductions. Renee, would you mind introducing yourself again?
Sure. Renee Bolio Banks, Indigenous cause, Jaganashumang, Sibikwe Indigenous Indigo, Zagasqua Jamaica, Gandunjaba, Magazine and New Dame. So that's kind of a general greeting and Ojibwe Moan. My English name is Renee Bolio Banks, and my spirit name is River Woman. I'm from Leech Lake, and I am the Eagle Clan. I've been at NACC for about, going almost 5 years. And I'm the elder in residence, one of the elders in residence. So we have spiritual care as well. So I do spiritual care and work as the elder. So nice to be here today, Miigwech.
Miigwech. There's a couple members of our team that couldn't be here today. We have Dr. Kari Rabi. She's our medical officer and family practice physician. And then Nikki Jardina is our infectious disease care coordinator nurse. And then I'm Lindsay King-Cooney. I'm the harm reduction and Midwest Tribal Echo coordinator. So we'll move on to some announcements. Share my screen. All right, so welcome again, everybody, to Midwest Tribal Echo. This is the Opioid Use Disorder Education and Treatment series. Today we have Adrienne Thayer from the University of Minnesota, and she'll be talking to us about her mobile nursing hook care unit. A little bit about NACC. So we're an FQHC. We've been here since 2003 in the urban indigenous community in South Minneapolis. We offer a wide variety of services. Our website is down there at the bottom. This is just a list of current open positions at NACC, so feel free to go onto our website to the job section and you can read more about those. Some session guidelines, please no protected health information. If you could mute yourself if you're not speaking. If you're feeling up to it, we'd love to see your face if you could turn on your camera. And then in the chat function, if you could just please let me know who you are, your name, title, organization, and email, and I can get information out to you, as well as the post-evaluation survey for today's session. Most of you probably know this, but we have the new Aya Echo format, so it just takes a couple of minutes to sign up. Once you do that, you get the link to the sessions and all of the information is all right there in one place. Some announcements. So our next Echo is coming up. We have on February 21st, Yarlix Estrada from Remedy Alliance is going to be talking to us about drug checking and their machines. And then March 6th, we have Kyle Lipinski and Gina Lancy, and they're going to go over solidarity and recovery within unsheltered communities. And then this is a list of other Echoes that we recommend that cover similar topics on opioid use disorder. And then we do offer CME credits for those who are eligible. We just ask that you fill out the post-evaluation survey to receive those credits. And then if you do have a case presentation, feel free to email me and let me know. They make for a great discussion during these Echoes. And I think that's it for me. I'm going to stop sharing, and then I'm going to welcome Adrienne again to present for us today.
Wonderful. Thank you so much, Lindsay and Renee, for that wonderful introduction. I just feel so honored and grateful to be here and be allowed into this sacred space. I always get so humbled by those introductions, so thank you. I'm going to share my screen and we'll get started. I'd also probably gonna put my email in the chat in case we don't have room for questions in the end, and anyone has questions that they want to send to me or comments, feedback, I'm always open for all of the above. There we go. Okay. So I am Adrienne Thayer. I'm a community engagement nurse with the University of Minnesota Mobile Health Initiative. The presentation I'm about to share with you is Mobile Nursing Foot Care, which was a quality improvement project that I did. I'm currently also a student at the U, getting a dual degree. I'm getting a doctorate of nursing practice and health innovation and leadership and a master's of public health. So this was my DNP project, part of my doctoral work. And I'm very grateful and feel lucky to have been able to do this with such a wonderful organization such as the NACC Street Outreach Team, but we'll get into that here as well. So this is our story. I always want to start off with, this is about heart-centered care and kind of bringing love back to healthcare, and stop making it feel so transactional for folks. I was an ER nurse for 10 years and it just felt so transactional in that role. And I believe in leading with love and leading with your heart. And this is kind of how 3 organizations came together to make, and listen to community, listen to the people doing the work, and made this project and program, which I think so we're going to kind of explain all the steps through that today. So we got here, I was hired in September of 2022. Mobile Health Initiative has been around for about 7 or 8 years, but they were in city of Minneapolis opioid response meetings prior to my arrival, like with lots of community orgs such as NACC and other orgs doing harm reduction street outreach work, kind of talking about, unique ways that we could deliver healthcare services and build trust in unhoused community. And that is essentially how they came up with the idea to hire a nurse. So we got a Mobile Health Initiative, got a grant from the city of Minneapolis. And then I was hired in September of 2022, kind of with a clean slate. The only thing I was told when I was hired was, we'd like you to work with community orgs and build trust. And it's kind of been taken off from there. So this is kind of that story of how we got there. So here's just the University of Minnesota Mobile Health Initiative. It started off screening migrant farm workers. My boss, Dr. Jonathan Kirsch, is an internal medicine physician. He started taking medical students down to do migrant farm worker screenings with community orgs that were working with folks down there. In 2020, they got a grant after the murder of George Floyd, a quite large grant where they were able to buy a large mobile unit and start kind of really expanding services. And like I said, and then I was hired a couple of years after that, as we kind of decided that we wanted to expand the model to hopefully unhoused folks as well. This is a picture of the mobile health unit. This was last year in the Cedar Riverside unit, but this is it's got 2 exam rooms. We don't really use this too much in the cities, but it's very helpful, like for big events that we're doing outdoors. So I just wanted to show a picture of that. That was the night sky. So the 3 organizations that came together, I see Dave Glanzer, the nurse, is on here today, and he was kind of my guiding light when I started this role, as I've been a public health nurse and a nurse for a long time, but I was new to street outreach. He works for Maytech, and he's the one who kind of introduced me to the NACC folks and kind of brought us all together, which is also, I'm forever grateful for that, because that connection kind of has really led to such a beautiful partnership and collaboration. This is the Native American Community Clinic outreach team and clinic staff. So I just have some photos in there of the wonderful folks that I've worked with over the last year and a half. I do want to talk about the future of nursing report. So every 10 years, NASM, National Academies of Science, Engineering, and Medicine, kind of puts out a 10-year perspective outlook of what they want nurses to do, right? Where do they want the nursing workforce as the largest healthcare workforce to go? They talked about, this report came out in 2021 and really talked about that nurses needed to start really, expanding outside of their normal traditional roles into more social determinants of health, teaming across boundaries, engaging diverse stakeholders and subject matter experts, Working with community partners can help nurses reach underserved populations was one of the things they stated. So I just like to point that out because there is some good evidence base to prove that that nursing really needs to expand in order to get new healing outcomes and better health outcomes for folks. We need to really start going outside of the box and working in a different way than we've traditionally worked in the past. So November 2022, this is a picture of us outside doing outreach. This is kind of when our collaboration began. That was outside of a large encampment in Minneapolis, South Minneapolis, near the House of Balls. I just like to add these photos so you can kind of see what we were out there doing. So, you know, like I said, I was given a blank slate when I started this role. I really didn't know what am I going to do? You know, I knew I was a nurse, I could assess, I've got some wound care skills, but I really wanted to kind of know what, you know, the community outreach workers were seeing, that they thought that, you know, we never wanted to duplicate any services. We just kind of wanted to add a nurse to teams and enhance what was already being done, the great work that was being done by folks. So this is just some of the qualitative methods that like to determine planning. You know, I observed a lot of the process. I participated in the outreach process, you know, tried to be a member of the team, and then really asking folks just informally, you know, what is it you're seeing that you're not able to address that's maybe outside of your scope? Asking some of the community when we would go out, is there healthcare needs that, you know, that you're not being able to have met that maybe I could bring out on a mobile level, and just really starting to gather some data to figure out how a mobile health initiative could really enhance some of the work that these street outreach teams were doing. So the need for foot care was identified pretty early on in my process of starting this role. I'd say within the first 2 to 3 months. It was identified at one of the city of Minneapolis meetings that we were doing, those weekly meetings. One of the directors of a harm reduction group said that they were seeing an increased need for foot care. It was kind of outside of the scope of their street outreach team. And me and Dr. Kirsch kind of talked about that this was inside of the scope of practice for nurses. So, you know, how could we meet the need and bridge the gap? So that's kind of how we got here. I just like to say that this is part of, I already kind of mentioned that I'm also a student. This was part of my DNP project. So basically, I then kind of took that needs assessment is always part of a DNP project. So then it was like developing, piloting, and evaluating. So figuring out how to build a program and a project to trial it and see if it worked for folks. And then really it was also about trying to build trust with people and bring healthcare to unhoused folks that maybe, you know, there's a lot of foot care services that are at brick and mortar institutions. There's some out of shelters, but there was really nothing that I was seeing in the Twin Cities that was bringing it to locations of where unhoused folks were at. This is just a really great quote that I like to bring in. Our work needs to be tethered by love. Love can be a potent medicine to heal the present as well as the future. So I kind of use that as my guiding light for this project. I started out with a literature review. So basically with all evidence-based quality improvement projects, you want to see what's already been done out there. You know, this wasn't research. It was kind of like taking what's been done and applying it to community. So I searched the literature to find out, you know, what's been tried, what didn't work, what did work, and were there any gaps in the literature? So this project did seem to be addressing a gap in the literature. I found a couple systematic reviews and an article that mentioned that mobile, you know, had taken foot care mainly out of shelter spaces, and then so this review by Toe talked about mobile interventions may be particularly effective in this population, given the high burden of unmet medical and social needs. And then another article by D'Souza et al. Stated that future recommendations would be to assess the sustainability of mobile foot care clinics. So it was kind of maybe taking what had been done and moving to the next step and seeing if it worked for folks. I also want to talk about like when I did my literature review, and I just like to add this in because there's really a lot of still stigmatizing language when you're searching these evidence based practice databases. And so I had to like look up the term homelessness, even though that term is very stigmatizing. And just want to talk about kind of how language has evolved into unhoused or unshelters or people experiencing homelessness, just to show more empathy and, you know, how sometimes you still have to use those stigmatizing terms to get to look up evidence to find out what's been done, and just kind of the evolution of language. So another thing I found was characteristics of healthcare providers that were providing the care, because as we know, I said that I was an ER nurse for 10 years. It was very transactional. You're seeing people at your worst, providing care out in the streets, and as a public health nurse. There was a lot of data on the type of person that, an attitude that you need to have to be able to actually effectively provide care to folks in their own settings. So, you know, building relationships, being really approachable, being reliable and consistent, being patient, time and attitude of the professional is important. You need to be empathic and loving. Self-awareness is crucial, constantly looking at yourself and your own implicit biases and your own ideals and personal experiences and how that has affected, you know, the way you view the world and your perspectives, having an open attitude, and then just lots of self-reflection. So I did find this, I always like to share this because I think that this really matters, especially in the state of healthcare where there's so much burnout and, you know, it can turn people away if they're not treated with love. I also added in that, you know, it's very important to honor the inherent wisdom and lived experiences of the unhoused community. It was really about co-creating solutions with them, and it wasn't more about like, what do you need and how can I help? I wanted to make sure that their voice was included in this process and that we were actually building a project and a program that would be utilized by folks, and that was something that they wanted. And, you know, bringing out the resources and supplies that were needed by the people that were being served. So my project aim was that at least 25% of the patients offered mobile nursing foot care would agree to receive the services. Like I said, this was kind of, you know, a new thing, doing it mobile. I didn't know how many people would actually want to like get in a van and, you know, soak their feet and have me assess them. So I aimed pretty low because this was, it was kind of a trial. It was a pilot. How is this going to go? And it was really to find out, you know, how much interest was out there to have this service. These are just some of the process objectives. So how did I get it set up? You know, I had to add nursing foot care and do a lot of research to add the assessment piece into our medical record of REDCap. We just have a very blanket medical record within mobile health. We're not really connected to anyone else, and it's really just for our personal use. And documentation. I needed to order all of the supplies, so I had to do a lot of legwork on that, on all the things that would be needed. And then I needed to build a mobile nursing policy and procedure, and have my medical director sign it and keep it in place on the unit. So I had to speak with a nursing professor at the U who had set up a nursing student mobile foot clinic, a nursing student foot care clinic in a community clinic years ago, and who had a lot of these documents so that I could kind of modify and base it off of that. So we started last year, God, it's been a year already, 13-week pilot from February to May of last year. I like to keep a picture of this van because I ended up having to rent a van. That big mobile unit was too big to be hauling around the streets of Minneapolis. So, and you really need to like have community buy-in to park it. And since people are moving around and I work with different community orgs, it just wasn't feasible to drive that in the city. So I rented a fleet van every week, and I would get it all tailored up for mobile foot care. These are the services that I provided or offered, and people, you know, I would tell people straight up, you can take as little as you want, you can take as much as you want. This is just what I'm able to do. So I had warm cleansing foot wipes, like lavender scented, that I kept in a portable baby diaper warmer that you could plug into the van. I did a foot soak with 3 different kinds of soap. I could do a foot assessment. I could provide any wound care if there was wounds. I had corn cushions that I could apply and send with the patient. Clipping toenails. I did a foot massage with lotion. Foot powder was applied. I had 4 different kinds of socks based on assessment or desire. And then I had a foot care to go kit. And then also I always offered a referral to primary care if desired. So the first time before I took this on the road, I wanted to make sure that I kind of, you know, had my ducks in a row and knew what I was doing. I didn't want to like test pilot this on a person out in the community and have them think, you know, what's this chick doing? So I ran through the first with my coworkers because I also wanted to know, was I missing anything? I had never really done this before. And, you know, when you're out doing street outreach, you want to be as prepared as possible. So we did it in our parking lot, like on a winter day. I set it up like I would with a patient, and then 2 of my coworkers, one was the patient, one was the observer, and we kind of rolled through everything to determine, you know, what am I missing? How would this really go with someone? You know, where would they set their stuff? How would I document? You know, all of these things. We learned a lot from that, so I'm super grateful we did it. I mean, I needed a ton more supplies. You know, I think we realized I had a trash, but I needed another cooler for the dirty water. I needed a place for patients' belongings. I needed to develop a self-care for feet pamphlet so that I actually offered some sort of a educational handout for folks that wanted that. There was just a lot of little intricacies that we learned from doing the like role-playing bit first. I then also, the week before I piloted, had been requested to go up to the homeless shelter in Chum in Duluth. So I went up there to do services, foot care services out of like a brick and mortar setting. So I got to pilot the entire process that I also would have done in the van that I mentioned before, like on some folks and get their feedback prior to taking it mobile, which was super helpful because then I was able to like ask people, you know, what can I do better? What did you like? What didn't you like? Is there anything you wish I would have done? These are some of the comments from participants. I wish the foot massage was longer. I loved everything about it. I would have loved to have this service when I was unsheltered. My feet feel so much better. And then the chair could be more comfortable, which obviously was kind of outside of my, it was just kind of the chair we were given. And so, but I'd like to add these quotes in. So these then were my outcome objectives. You know, what was I going to measure when we were out there to see if this was working for people or if people liked it? So my number 1 was that at least 12 people would receive mobile nursing foot care over the 13-week pilot. I mean, I was shooting for 1 person to say yes per week. That was kind of the goal, just to start really low barrier. 80% of the people receiving mobile foot care would be offered a primary care referral. Would be offered. They could decline it, but just that I offered it to them. And then 50% of the people receiving mobile foot care services would verbalize satisfaction with their care. So these were kind of the 3 measures. I just asked people questions at the end. If they wanted to answer them, they did. If not, that was fine too. And then I also asked if they, you know, had any recommendations for improvement or any like qualitative things they wanted to tell me so that I could make it better for the next person. Because I told them this is like an iterative process. I just want to make it better for folks. If it's no good, you know, we can scratch it. So these were the measures. So I worked with 2 different outreach groups, NACC and Aliveness, for the implementation period. One was kind of a park in the same place, same time, same place model. And then the NACC team, they go out and find where tent encampments are. So we moved around, and we were mainly on foot as well. Whereas NACC aliveness parks in a certain location at the same time. And so it was two different models. So it was also kind of testing which one worked better as well. These are the results from the foot care pilots from each week. So I kept track of how many people I offered it to, how many people declined, how many people said yes and received, how many people said yes and didn't receive for some other random reason. So 13% agreed to receive foot care, which was obviously below my aim of 25%, but I still consider this a win. But I just like to show this graph to kind of see where we were at. Primary care referral results. So 84% of patients were offered a primary care referral. Only 4 of those people, so I think it was 11 total, and only 4 of them actually agreed to a primary care referral. Most declined. Some people already had primary care. I think the problem that was found with this was it wasn't like I could make an appointment for someone. It was really, a lot of folks didn't have an address or a phone. So like trying to get them registered in a system really wasn't feasible. So it was really the 4 that did agree. It was really more about teaching them how to use the walk-in clinic systems at like NACC or NACC, which are both FQHCs, based on, good times to go, when they could be seen, hours they were open, and like location. I think this is like where there's some room to do maybe some more quality improvement projects down the line about how we really can get people in to be seen in primary care settings if that's what they'd want to do. 100% of patients verbalized satisfaction with their services, which was awesome. 92% of them stated that their feet felt better after their foot care encounter. These are just some of the qualitative statements that were made by participants. I just always like to add these in, my feet feel so good, I will vouch for you. I did have a lot of folks that actually brought back like their loved ones on another day or the same day. I'll give you 5 stars. I didn't expect to get a foot massage. These are some unintended consequences. So 2 people agreeing to receive services at the same time. Obviously, I was only a 1-person show with a 1-person setup in my van. So if 2 people agreed at the same time, I'd ask like the person that said yes second if they could wait around, and probably due to the cold weather, or competing priorities, by the time I was done with the first person, they were not usually there waiting for their turn. Especially because, like I said, I was trying to not make this transactional. So I took as much time as needed with folks. I'd say pretty much every encounter was an average of 20 to 35 minutes. I also think that the cold weather had something to do with the low output of people that agreed. Only having 1 nurse to perform the foot care services.
Adrienne, can you hear us?
Thursdays I was going out with NACC was difficult too. Can you see me? Am I frozen?
You were for just a second, but I think it's good now.
Okay, sorry about that. Okay.
No.
So all of the process and outcome objectives were met during the 13-week pilot. Sharing of stories during the foot soaking process was probably my favorite part of this, just like listening to people share their stories about their life or their health or, whatever had happened that day. I think that, storytelling can be so cathartic for folks, and it really just developed a bond, and it was just a better healthcare experience for all. Some people actually did want to talk about other health problems. Some people didn't, and that was fine. But some people, did ask about, certain other, really good health questions, and I was able to, find the information or give them the information, or even sometimes I had supplies, over-the-counter meds, wound care kits, things that I could, like tangible items I could hand to them to kind of like bridge the gap of some of their health concerns. And then, like I said, some people came back again. I didn't count them in the numbers of total seen, and then some people brought their loved ones back. Strengths of the project, so sustainability and kind of growth was I did have some new community organizations express interest in partnering with Mobile Health Nurse for foot care services, which was awesome. And then I was invited to perform foot care at some brick and mortar harm reduction events. I'm still kind of getting invited to do that, which is great. One thing I also found was that when you take it on that mobile level, you can also just, if you have a room somewhere and you want me to bring it in there, it doesn't always have to be out of the van. It's very malleable that way. You can kind of take it and do it wherever. So yes, like I said, it kind of expanded. It's not just foot care. So what we're offering now, foot care, wound care, handing out over-the-counter meds, which is probably the most of what I hand out when I'm out with community partners. Wound care kits, socks, warm weather supplies has also been added now, snacks, beverages. I try to bring out, kind of like I said, we don't want to duplicate efforts, so try to bring out things that the community partner isn't bringing out so that we can just expand what we're providing for folks. There's more participants now than there was during the pilot period. I'd say except for this last month. This last month has been kind of dry with foot care, which is okay. There's going to be months like that. And then my partnership with NACC kind of shifted to the same time, same place model. Excuse me. Just because we were finding bringing the van out when we were going to tent encampments, that just didn't always work very well. People seem to be really comfortable that their tent is their home, and kind of asking them to come out of the tent to come into a van with myself, that can get a little, it just wasn't really working out so well. So now I go every Monday. We decided to trial that in the last summer, which has been working really well, to go to NACC's HIV testing event in the back of their building on Mondays, and then bringing the van and offering mobile foot care, and then all the other supplies and wound care kits and stuff on that day as well. I also like to put this quote in here just because this guy, Dr. Donabedian, was the father of healthcare quality. And I always love to find evidence to back up my love ethic for healthcare. But basically he stated that systems awareness and systems design are important for health professionals, but they are not enough. Ultimately, the secret of quality is love. If you have love, you can then work backwards to monitor and improve the system. These are just some of my acknowledgements, the people that helped me work on this project. And then, I always will shout out to my wonderful NACC outreach team, because they've been so great to let me be included and kind of build off the trust and their expertise that they've built. And then all the patients I've come into contact with while doing this work, they inspire me, and I just deeply thank them. So that's all I have for slides. I don't know if I'll stop sharing here. If anyone has any questions or comments, I would love to hear them or answer them.
I think I see Dave. Dave, do you have a comment?
That actually went faster than I thought, so I'm sorry if it felt like I rushed through that, but I get very excited about this stuff, so
That was awesome. Thank you. Dave, I don't know if you were going to make a comment, but I think you're kind of cutting out.
Sorry, I was just curious about what is planned in the future, stepping up this great project.
Yeah, no, that's a good question. Well, I mean, kind of the next steps now are, we just got another grant from the city of Minneapolis after that trust building grant. And so, you know, my dream world would be to hire a peer recovery specialist / community health worker. So we did get funding for that. So we're in the midst of trying to hire that person now to kind of expand my team. And then we're also trying to get funding to do mobile STI testing. There's one, we just got denied another grant on that. Nobody really wants to take up this idea, unfortunately, but there's one machine, a Binks machine, and that's FDA approved in the United States. It does 30-minute turnarounds on like 3 or 4 different STIs: chlamydia, gonorrhea, trichomonas, syphilis. So ideally, and then, you know, then I'll be able to treat, you know, the 30-minute turnaround with a self swab or a urine collection sample, and then be able to treat I can carry up to like 10 doses of antibiotics for each with my nursing license under my medical director's name, per time I go out. So being able to treat all in one test and treat all in one episode. The other thing is in the next month or two, that big boy unit you just saw, we're trading it in for a new one. We're like about a month, 6 weeks out for that to get a smaller one. That's about 10 feet shorter with a bathroom included.
Oh, Adrienne, I think you're frozen for me. I'm not sure for others.
Meantime, we could do wound care, we could do some care coordination. Hopefully we'll expand into, oh, I'm sorry, am I freezing?
You did again, just for a little bit, but
Okay, I'm sorry, something's wrong with my internet. So hopefully we'll expand into the peer recovery specialist, community health worker can give people rides right away, because we're kind of realizing when people want something, they kind of want it or they're ready then. And doing some more mobile Suboxone, telehealth. You know, the vision is kind of just showing up for what the needs are, starting to really document that, and then kind of looking at what resources and bridges we need to build to meet the needs that we're not able to, obviously, within our little scope.
are you gonna continue to try to go to encampments with the foot care services, or do you have any thoughts on how to kind of get folks to want to get those services in that way, or are you kind of sticking to like more of the brick and mortar? Or
No, I would like to bring that. I'm hoping with the newer unit that's a little bit more professional and not just a van, that maybe then we can start trying that again, and especially on those Thursdays we go out. And then maybe parking and seeing if people, you know, at least that consistency model matters. So parking and seeing if people want to try something like that. And maybe with offering like the STI testing or offering more services, folks will maybe, you know, feel a little bit more comfortable, because if we got to wait that 30 minutes, maybe they'll want to like soak their feet or have me assess them while we're waiting.
sure.
And really, I want to get more feedback from participants too, to see what would work, what wouldn't. You know, I think that that's really where the feedback piece, and just keep asking the questions, will make a big difference. Does anyone else have any questions, comments?
Sorry, I have one more just about Greater Minnesota, and I didn't,
Yeah.
maybe what you have other thoughts about or things you've done that that are looking forward to doing more of.
Yeah, like we do those harm reduction pop-up events in Greater Minnesota. So bringing the foot care to those has been wonderful. I'm also just talked with the Chum folks yesterday, and we're gonna start doing monthly events with them through the fall. So we have all that on the books now, which is great. And hopefully expanding even to their low income senior housing eventually and bringing that mobile unit over there. The other thing is we've been invited like through St. Louis County to start being included in their community connect events, which is wonderful because there's so many services provided at those. So to be able to table and offer and enhance more services is an honor to be included in those as well.
Adrienne, is it okay if I share the slides from today with the group?
Absolutely.
Okay, cool. Yeah, I can do that. And then, yeah, if anyone has any other questions that they think of later on, we can definitely feel free to email me. Adrienne, did you put your email in the chat or do you want me to? Otherwise,
I'll put you right now.
okay, cool. All right, well, I just want to say thank you, Adrienne. We really appreciate you. We appreciate your partnership, and it's just reassuring to know there's people like you out in the community serving in such a thoughtful and loving way. So we really appreciate you.
Well, thank you. I appreciate you all so much too. So thank you.
And thank you everybody for joining today. We'll see you hopefully next ECHO February 21st. So have a good day. Thank you.
Thank you.